Let's jump right in. I want you to picture this. You're an ICU doctor. You have a patient, they've got a life-threatening infection, and to make matters worse, their kidneys have completely shut down. Now, you've got the antibiotics to save them, but here's the catch. The very dialysis machine that's keeping them alive is also sucking that medicine right out of their body, and it's doing it in a totally unpredictable way. You give too little, the infection takes over. You give too much, the drug itself could be toxic. It is, without a doubt, one of the most high-stakes calculations in all of medicine.
So this is the billion-dollar question, isn't it? What is the right dose? For years, the answer has been, well, a bit of a shrug. A really dangerous gray area for the doctors on the front lines. You see, a patient on dialysis is in a constant state of change. So how in the world do you hit a moving target when a life is hanging in the balance?
And make no mistake, this is not some academic exercise. Getting this wrong can, and often is, fatal. But this is also a story about how a massive, global team of researchers basically went on a medical detective hunt, looking for the clues that could finally replace dangerous guesswork with life-saving science.
To really get why the solution is so brilliant, we first have to understand just how big the problem was. We need to talk about the huge knowledge gap doctors were dealing with day in and day out.
And this is what's truly terrifying. Studies were showing that in up to 40%, let that sink in, almost half of these critically ill patients, the antibiotic levels in their blood just weren't right. They were either too low to fight the infection or so high they risked toxicity. That is a massive margin for error.
And the researchers themselves said it best. There were no universal recommendations. There was no playbook. Doctors were facing one of the toughest clinical challenges you can imagine, and they were essentially flying blind. It was like navigating a storm without a map.
Okay, to solve this puzzle, we have to understand a concept called pharmacokinetics. Now don't worry, it sounds way more complicated than it is. Just think of the drug level in a patient's body like water in a bucket. Your kidneys? They're like a small, predictable drain at the bottom. But when your kidneys fail and you go on dialysis, you've just drilled a huge, powerful, and super unpredictable second drain into that bucket. And the whole problem is figuring out exactly how fast that new drain is working. So this is where our heroes of the story come in. You see, a problem this big and this complicated couldn't be solved by one hospital. It took a massive international effort, a study called SMART. And when I say massive, I mean massive. We're not talking about a dozen patients. We're talking about 300 critically ill people in 22 different ICUs spread across 12 countries. The sheer logistics are mind-boggling. They ended up collecting and analyzing over 8,000 biological samples to get the raw data they needed.
Their mission was crystal clear. They were going to take all of that data and use it to build the world's first reliable, scientifically backed dosing guidelines for two of the most common workhorse antibiotics used in the ICU. They were going to write that playbook that doctors were so desperately missing.
And how they did it is just a beautiful example of science at its best. First, they gathered a mountain of real-world data from actual patients. Then they fed that data into powerful computers to build these incredibly sophisticated models of how the drugs actually behave in the body. And finally, they used those models to run thousands upon thousands of simulations, testing every what-if scenario imaginable to find the absolute best dosing strategies.
And after all that painstaking work, the data started to talk. The investigation started to reveal its secrets. It all boiled down to just three, absolutely critical factors that were the key to the whole puzzle.
Now, these weren't just some minor details. No, these were the main drivers, the big levers that controlled the drug levels in the body. If doctors could just measure these three things, they could finally start personalizing the dose for each and every patient.
The first key was the intensity of the dialysis machine itself. Remember our bucket analogy? Well, a more aggressive, high-intensity dialysis setting is like a much bigger drain. It just pulls the drug out of the body that much faster. So, puzzle piece number one, you have to know how hard the machine is working. The second discovery was a big aha moment. It was all about the patient's own body. Even when a patient's kidneys have failed, they might still be making a tiny bit of urine. And what this study proved is that even a small amount makes a huge difference in clearing the drug. You have to account for both the machine and the person.
And the third factor? Honestly, this one was a total game changer. It turns out it's not just about how much drug you give, but how you give it. Do you push it all in at once over 30 minutes? Or do you give it as a slow, steady drip over many hours? The answer, as they found out, matters a lot.
And the difference is just night and day. A short infusion gives you this huge spike, but then the level plummets into a valley where it might not be effective at all. But a continuous infusion, that's like keeping the top on just right, maintaining the steady, effective drug level the entire time. It was consistently better and, get this, you could often use a lower total dose.
So with these 3 golden keys unlocked, dialysis intensity, urine output, and infusion time, the researchers could finally build the tool that ICU doctors everywhere had been waiting for.
And here it is, the solution. They created something called dosing nomograms, and really, all they are simple, easy-to-use charts. They let a doctor, standing right there at the bedside, take these few key variables and find a precise, scientifically proven dose. No more guesswork.
Let's make this real with an example. Look at this chart for the antibiotic meropenem. If your RRT intensity is low and your patient has very little urine output, the dose is pretty small, 1 to 1.5 grams. But look, if that same patient on the same machine starts making more urine, the recommended dose literally doubles. That is personalized medicine in action.
So now, the whole decision-making process becomes this beautifully simple 3-step algorithm. Step 1, what kind of bug are we fighting? Step 2, check the 2 patient factors, RRT intensity and urine output. And step 3, look at the chart and find the right dose. It's clear, it's actionable, and it's built on a mountain of evidence. Okay, so this research is obviously a giant leap forward. But, science is never really done. It's an ongoing conversation. So let's talk about the impact of this study and the questions that still need answers.
The strengths here are just undeniable. It's the biggest study of its kind. The computer models are rock solid. But maybe most importantly, the recommendations are actually practical. They're based on things a doctor can easily measure at the bedside, right now. It gives them an incredibly powerful tool for clinical practice.
But of course, good science is honest about its limits. The authors are very clear that we still need more research on different kinds of dialysis and for patients at the extreme ends of the weight spectrum. And the ultimate next step? A huge randomized clinical trial to prove that getting the dose right with these charts actually saves more lives.
And really, that brings us right back to the beginning. The SMR study has given us an incredible new playbook, built on amazing science and a ton of hard work. It has the very real potential to turn one of the most dangerous gambles in critical care into a precise, life-saving science, making sure that more patients get exactly the right dose at exactly the right time.